sometimes the thoughts that you get for cigarettes that occur weeks after you quit smoking or months after you quit smoking may hit you harder than the thoughts or the urges that you had in the beginning of quitting smoking. And that often catches people very much off guard. You know, when you have a bad urge the first day and the second day, oh, that's no surprise. You were anticipating that. Often you expect it to be a whole lot worse than quitting actually is. So when you get those thoughts, when you get those urges, no, they were par for the course. But when you're off for weeks or months, and then all of a sudden, out of nowhere, at least that's how you're seeing it, out of nowhere you get a real strong thought for a cigarette, it can catch you very much off guard, which makes it a little bit rougher on that level. And you'll often hear yourself saying or thinking like, oh man, it's just as bad as the day I quit smoking. And what's interesting is some of those thoughts that you get may hit at the intensity of when you quit smoking. And then you start to think like there's no difference now between, the thoughts you were getting in the beginning, or the urges you were getting in the beginning, and the thoughts you're getting now. There really is a difference though, and it's a big one. The difference is the thoughts that you were getting in the beginning, the urges, they're physiological. Some of them are psychological, but some of them are physiological. They're true physical craves for nicotine. You're in a drug withdrawal state, your body is demanding nicotine. You're in drug withdrawal. Now, sometimes you'll get very well-meaning, but pretty useless advice from people around you. You're having a physical urge, a craving, an urge, whatever you want to call it. Your body wants nicotine. And the only thing that's going to stop that urge is delivering nicotine, or not delivering nicotine and writing it out. But the advice you're going to get from people when you're getting that physical urge is, oh, well, don't think about it. It's like telling somebody who has the stomach flu or food poisoning, and the primary symptom they're having is diarrhea, to reassuringly tell that person, oh, well, just don't think about it. Yeah, don't think about it, but hang by the bathroom anyway. You're having a physical symptom. Not thinking about that symptom doesn't make the symptom go away. What makes the symptom go away is, overcoming the time period that the stomach flu was existing, or in the case of if it's a food poisoning, is getting an antibiotic to treat the bacteria that's causing the reaction. So giving the advice of, oh, just don't think about it is ridiculous when it comes to a physiological issue. It doesn't make it go away. But the thoughts that you're getting down the line, they're not physical. They're psychological. They're being triggered by a circumstance. The way that I try to illustrate this when I would do clinics is I would use the comparison between a physical and a psychological pain when it came to something like a toothache. And I would always explain, to the group, I'd ask, has anyone ever had a toothache? I mean a real toothache. A toothache where you're not calling the dentist and looking for an appointment tomorrow, and you're not looking for the earliest opening next week. You've got a toothache. You're in pain. And you tell this to the dental office. And you know what? They're not looking for an open appointment. They're saying, come on in. They realize this is an emergency. And dentists, they know they have to schedule around things like this. They have to accommodate people because this is a true physical pain. All right, so you go to the dentist, and you have this terrible, terrible toothache, and you go to the dentist, and they have to, do their little probing around the mouth, and they may run their x-rays, and they're trying to find a problem, and, finally with the probe, they hit the tooth, and it sends this jolt of pain through your brain, like, it's just very intense. So now they know the tooth, now they x-ray it even better, and they get the tooth, and now the dentist comes in and tells you the situation. He explains, you've got this, rotting tooth, and it's affecting this nerve, and they show you the picture of the nerve, and, they may be very, calm in their description and describing what's happening, and they give you a real good detailed explanation of why you're in pain. How do you feel as soon as you got this nice lengthy description of why you're in pain? You're probably furious at this point. You see, you didn't go to the dentist to get pain described. You already understood pain. You wanted the dentist to treat the pain. You wanted the dentist to give you Novocaine. You wanted the dentist to pull the tooth. You wanted the dentist to put a bullet through your brain. You wanted to stop the pain. That's a physical pain. understanding it doesn't make it go away. Again, it's like just thinking about something else. It doesn't make it go away. It's physical. It has to be treated. Okay, now let's look at a psychological pain. And the way I would do this with my smoking clinic people, I would always ask, and this probably wouldn't work anymore because it's kind of dated. And so some people who are hearing this will probably not know what I'm talking about. But there was a movie, I think it was in the 80s, called The Marathon Man. It was with Dustin Hoffman, and it was some sort of spy thriller. And there was one scene in there. And what I would first do is I'd ask the group, who here's seen The Marathon Man? And you'd see a number of hands go up. And I would ask one of them, hopefully someone in the front of the room so everybody could see the reaction, or someone in the back of the room so if everybody is listening they have to turn around to look at the person in the face, because that's what I really wanted to do. I wanted people to see the person's face. They didn't know what was coming. And I would say, do you remember the scene where they're drilling into the guy's tooth for torture? And I would try to emphasize the look on my face on what it's like. And then the person who saw the movie, there would almost always be a reaction where you would see either a cringe or you would see them go, oh yeah. And it was like an instant reaction because it was a scene where they were torturing a guy by drilling into his tooth. Now, the reaction was intense. The reaction was like, oh my God, and it was a horrible look on the person's face often. And I would point out to the group, what just occurred. It was like, and I got to point out, it wouldn't work on all participants. It would only work on a participant who ever had a cavity filled or whoever had a severe toothache. See, if a person never had a severe toothache or a cavity filled that caused them pain, they wouldn't know what was going on. But a person who had it, it would be an intense reaction that you would see. And I would point out that the person wasn't in pain, or even I pointed out to the people who were in the groups, I said, do you remember the reaction in the movie theater? What your reaction was, what the people around you's reaction were. And again, there was this automatic kind of cringing that everybody was having and reaching for their mouth to protect it because of this horrible scene. And it was a type of thing that when I pointed it out, I said, listen, when you're in the movie theater, and when you're in the clinic hearing the story, there's no drill on your tooth. There's not going to be a drill on your tooth. You're sitting in a movie theater, and you're having that same reaction you would have if somebody was coming at your tooth with a drill. It was a psychological association that you were having to the sound, to the scream. For those of you who never saw a movie like that, you're going to a dentist. You're getting your teeth cleaned. You don't have a cavity. You hear a drill in the next room and you hear someone screaming, you watch your reaction. It's like, I'm going in there next, and you don't want to go. But again, it's psychological. As soon as you realize you're not in pain, you're not at risk of being in pain, you can push the thought out of your mind at that point in time. That's the difference between the physical urges that you get in the beginning and the psychological urges. You can squelch the psychological ones. As I said in the early part of this, the physical ones, you can't squelch. They run their course. The psychological ones, you can push them out of feeling that they're a risk to you, that they're a threat to you. It's not necessarily by not thinking about it. It's just by focusing, again, on why you quit, why you don't want to be a smoker again, and realizing, that this thing triggered it. Whatever it was, this was an association that triggered it. Sometimes you won't even figure out what the association was. Something will trigger. It may be a smell, it may be a song in the background, it may be a person you see, it may be an aroma. It could be anything. And sometimes you won't figure out what the association is. But if you don't take a cigarette, you'll still break the association. So next time you encounter that same scenario, it won't trigger. It's a learning process now. It's just doing things you did before without taking a cigarette and breaking these associations, understanding that some strong thoughts may trigger some strong responses, but those responses are of no threat to you. They're not going to put you back to smoking. A thought can never put you back to smoking. Only one thing can do it, and that's giving into the thought and administering nicotine. As long as you don't administer nicotine, you'll never deal with the physical aspect of this again. Once you quit, to be able to sustain that quit for the duration of your life, it's still, even under times of triggers and thoughts, it's still just remembering that you made a commitment and then sticking to that commitment to never take another puff.